Okay, so we have a topic, Ebola virus disease, updates, epidemic preparedness, and IPC measures. As we all are aware, Ebola virus remains a critical public health threat with significant implications for not just for our health system, but for our communities and also the global health security. And so today we're not just looking at Ebola virus disease, but we're confronting some of the hard realities of preparedness and also the indispensable role that IPC has to play in saving lives. And today, taking us through today's topic is no other person than our amiable Dr. Adefolarin Opawoye. Sorry, sir. He is a consultant in internal medicine with specialization in infectious diseases at Lagos University Teaching Hospital. He obtained his medical degree from the University of Ilorin Teaching Hospital, did his residency training at the Lagos University Teaching Hospital, LUTH, and the Aminu Kano Teaching Hospital, and obtained a master's in public health from the University of Lagos. His foray into infectious diseases started in 2014 when he was one of the first indigenous doctors involved in the Nigerian Ebola emergency response. He has since been involved in several other outbreaks, including Lassa fever, monkeypox, yellow fever, etc. He led the Lagos State Infection Prevention and Control Team during the COVID-19 outbreak. His interest includes outbreak response, infection prevention and control, antimicrobial stewardship, and occupational health. He is the corporate medical advisor to Ando PLC, one of the largest indigenous oil and gas firms in the country. Aside medicine, he's a comedian and an expert compare. He is a Christian. He's married to a lawyer and blessed with 3 children. Please let's do well to welcome our speaker with our best emoji in the chat, Dr. Adefolarin. It's a pleasure to have you here today, sir. Thank you so much for being able to join.
Thank you very much. Thank you. It's wonderful being here. Thank you so much. So, I don't know. I think I should share my screen, right?
Yes, I've stopped sharing from my end. Go ahead.
Okay.
Thank you.
Mhm. Okay. Is my screen visible?
Yes, sir.
Okay. Thank you. So I can start, right?
Yes, go ahead, please. Thank you.
Okay. Okay. Thank you very much. So, thank you so much. It's great being here. It's a privilege and an opportunity to be with this wonderful group of individuals who are committed to changing the landscape of healthcare practice in the country and improving the quality of care. And this is a very topical issue because of the current outbreak in Congo, and more recently because of some other reasons that we're going to discuss. So over the next 30, 45 minutes, we're going to be going through Ebola virus disease, epidemic preparedness and infection prevention and control measures. And we are going to be quickly discussing the outbreak in Congo, previous outbreaks in Nigeria, and what we need to do as IPC professional. I'll try to stick with the IPC because I have infectious disease. So this is a bit of what I do in terms of even management and all. And I'm sure you are with me in praying that we don't have issues. So Ebola virus disease is caused by the Ebola virus. It's an RNA virus. It's a filovirus, belongs to the large family of filoviruses, and it has high mortality and epidemic potential. The 2025 Ebola outbreak in the DRC is the 16th outbreak in the country ever since the virus was first discovered in 1976. So it's important to note that the virus was first discovered in Congo. In fact, the Ebola is the name of a river in Zaire then, which was what it was called. And that's why the first virus is called the Zimbabwe. That's the Zaire Ebola virus. And they had quite a few outbreaks there in the place. And what we want to do here, the virus was first discovered in 1976. And what we want to try and do is to find infection prevention and control practices very crucial in Ebola virus disease. In fact, it's interesting to note that IPC was really domiciled in Nigeria initially as an outbreak response. And it took the efforts of a lot of people, particularly from ICANN, from NSIC, to try to train people that IPC is not just about responses. It's a way of life. I remember that used to be one of our logos and our tenets then, because you see when these outbreaks happen, there's a lot of hand washing, there are a lot of protocols, and then immediately the outbreak goes away, we go back to status quo until the next problem, And what has been done is to say that, look, IPC is not just about the outbreaks, but during outbreaks, it really goes up. And I can assure you that a lot of the exposure that IPC is getting now was actually because of the COVID-19 outbreak from 2020 to about 2022, 2023, So what we want to do is to protect healthcare workers from infection, which you will see during the presentation is very crucial, provide safe and effective care to patients, prevent nosocomial transmission within healthcare facilities, limit community spread, and protect public health. So in terms of Ebola, it's important to note that, and a lot of the other viral hemorrhagic fevers, is not just about the hospital alone. So this one, this time around, we go into what we call the community IPC, where we try to also see what's going on in the community and help, because if you don't do that, you're going to get overwhelmed with cases. And then you also want to implement effective triage, isolation, and standard precautions. So let's talk about the current outbreak in Congo DRC. And this outbreak is the 16th outbreak, like I've said, and it's in the Bulakwe and Mueka health zones within the Kasai province. So that's a bit of significant information because so far it's sort of like located in the rural areas. It's not in the big urban centers yet, because if it's in the urban centers, then that is a big problem, because that's where it will spread to other parts of the world, So there's a level of preparedness that we have now, but the alerts are still a bit low because it's not in the major urban centers yet. And what they are really desperately trying to do in the Congos is to limit the outbreak to those areas as much as possible to make sure it doesn't hit any of the major urban centers, So, but then let's look at what happened. August 10, in Congo, the index case, it was a 34-year-old pregnant woman, which nobody seems to know where she got it from, but they are thinking that initial contact may be with an animal, and she developed symptoms, And by August 20, she was admitted to the local hospital. August 26, she dies, and she was buried without any particular precautions being taken. August 22 to 28, 3 healthcare workers develop symptoms, okay? And usually that is the first sign that there's a problem. The healthcare workers are like the canary in the mine that signal to the rest of the world that there's an issue. If she had died and that's all, I'm sure there will not have been any alarm raised. But because she died, and before you know it, healthcare workers are becoming sick. People started raising alarms. And by September 3, there was laboratory confirmation of Ebola. And Ebola is one condition where one case is an outbreak, okay? Because you don't want to have any cases. You understand? An outbreak is said to be when you have more cases than expected per time in a particular location. But one case of Ebola is enough to trigger an outbreak, okay? And so an outbreak was declared September 4, 2025. And that was when the Congo Ministry of Health, they wrote an alert to WHO to declare that as an outbreak. And by September 6, the NCDC issued a public health advisory. Now let's go back to Congo, and this is September 25. The latest information we have, I believe, as of yesterday, showed that there have been 57 confirmed cases and been 37 deaths. Okay, with given a case fertility of 64.9%. That's brutal. And that is what we've come to expect with such a deadly virus like Ebola. And unfortunately, 5 healthcare workers have died. And that is why this is very crucial and it's very important to us, because there's a disproportionate toll that this terrible disease takes on healthcare workers. We live at a time when if you are practicing in Nigeria or probably in every African country, you understand the problem of the so-called Jackpot syndrome and the toll that the migration is doing to us. A lot of people are very busy. There's a lot of work to be done. There are too few hands. So every single healthcare worker is precious. And if we're complaining in Nigeria, I can't imagine what's going on in Congo. And then now you have 5 healthcare workers already dead. Today's terrible. And that's just within 3 weeks or thereabout to this terrible virus. And that's why it's very, very, very important for us, because it's usually the death of the healthcare workers the signal that there's a problem. But the people that have died cannot be brought back. And that's why I'm grateful for this opportunity to make sure that we try as much as possible not to allow something similar to happen to us in this country. And from the genomic sequencing that was done on this particular virus, it was believed that the initial contact is from the community, and it came down to the healthcare workers to the index case from there. And then there was no nosocomial transmission in the hospital, as always, of course, with this case, because there's always a failure of precautions, failure of standard precautions that causes that. When you come down to Nigeria, like I said, public health advisory was released in the September 6th. And since then, we've had 2 alerts, so to say, from Abuja. Interestingly, 2 alerts were from Abuja. I don't know, maybe because Abuja is being very watchful. Incidentally, one of the alerts was also a pregnant woman who went to National Hospital in Abuja with fever, and her husband was from Congo, you know. So immediately there was a lot of fear and apprehension, and she was placed in isolation. The response teams were called, and eventually discovered that the husband hadn't been to Congo in about 4 months, as opposed to weeks. So when they discovered that the alert levels were lowered, because we know the incubation period is about 2 to 21 days, so 4 months is a long time, and it's not likely to have been a problem, you know. So the alerts were reduced, and the patient was managed as a standard case of fever following our usual protocols. Now, the other alert case was more frightening, again, because somehow that particular case got out into circulation, where we had a young man who went to Rwanda for a holiday, and he came back. He had about 3 weeks of fever, and I think he also had some associated bleeding. So when he came in, there was a lot of fear and apprehension. Also, incidentally, he landed in Lagos and then moved to Abuja. And unfortunately, at that point, the internal memo actually sort of got passed on social media, created a stir. And eventually, the case was tested and discovered to be negative. But these are the canary in the mine kind of cases. These are the warning signs that we may not be as isolated as we think. We may not be as distant as we think. Congo, we may think it is far, but it's clear and obvious that it's not far enough. The world is a global village. And now that we are having these alerts, it's very important for us to get ready so that, God forbid, in case we are not caught pants down like it happened in 2014. So let's go to 2014 as the period outbreak in Nigeria from July to October. And it was we had an outbreak then, which was part of a larger outbreak in West Africa. Probably was much worse in Sierra Leone, in Liberia. And we had our own share of cases when the index case, a 40-year-old Liberian American, came in from Monrovia in Liberia through the airlines. And there was a bit of screening that was going on at that point, but it sort of lied about the symptoms, which is not unusual. And then before you know it, it was admitted. It came in July 20. Same day, was admitted at First Consultants Hospital in Obalende. And in fact, the only reason why he went to that hospital was because the enemy was on strike. If not, it would have come to a public hospital, and I don't know what the story would have been. And then by July 23rd, he tested positive. And we all know that the Ebola story in Nigeria can never be told without mentioning the contributions of Dr. Ameyo Adadebo, who literally stood in the gap and made sure that this man, she literally blocked the door of the hospital to make sure that this man does not leave, after he was initially diagnosed. And unfortunately, she didn't make it herself. And then the index patient died July 14. We had so many cases throughout July and August, but somehow we're lucky and we're able to be declared free from Ebola by October 2014, about 21 days after the last case. It's interesting also to note that two states were affected. That was Lagos and Port Harcourt. And the case in Port Harcourt was because one of the people that was a close contact of the primary case, the index case, who was a diplomat, they were working in the same office. He ran away when he was diagnosed and contacted his school colleague, who was a doctor in Port Harcourt, to say, this is the problem. And the doctor in Port Harcourt says, so come over, I'll sort you out. And then came in, and the doctor admitted him in an hotel. And eventually, unfortunately, the doctor died. The patient survived. That was how it got to Port Harcourt. Then there were other cases in Port Harcourt from there. The doctor's family, his wife, everything. I treated the wife myself. And but there were no other deaths, if I could recall very well. And that was how it was. It was seen as a triumph of public health structures, but for those of us who were a bit closer to the action, we knew, well, because I'm a believer in God, we say it was divine providence because we didn't have good structures in place. There was a lot of confusion. Incidentally, the current DG of the NCDC, Dr. Jide Idris, was the Commissioner of Health in Lagos at the time. And these people played pivotal roles in trying to make sure that this thing didn't go far. But we're learning as we moved. We're learning we're learning on the job, and we're very lucky somehow that things did not deteriorate too much. But I wouldn't express our success to any special public health maneuvers or anything. We knew a lot of the backstories, and they were not fun at all. But somehow we got away with that. We also got away with it during COVID. We don't know whether we'll get away with another time, but by now we should have a robust health system that we can use to deal with these problems. These are some of the pictures and images from the last outbreak we had in 2014. And there we were this was where we admitted the patients then in the infectious disease hospital in Yaba. We call it mainland hospital now, so that there'll be no stigmatization. And we could see this dressing our kit up there, the full overalls with the apron, everything, hoods, and all that. And here we're preparing to enter the isolation ward. I think this was my first time in the isolation ward. I was one of the case managers, and that was with a colleague. And we can see the other picture there with. I'm not sure if that was the DG of the NCDC at the time, Professor Nasidi. But he also came around and were shocked when he went into the isolation ward. We could see the foot. Must put your leg in the footpath before you enter. So a lot of things have changed with regarding even IPC practice in Ebola. We don't necessarily need to wear some of these things. Some of these things were also the same, but some of the things have changed, and that's what we're going to be highlighting here. Some of those things we could see training people and trying to get in the body system about dressing. And by this time, we're already getting better with the dressing to say that not everybody has to wear the full coverall. We can wear the surgical, resistant surgical gown, and that's enough. And like you can see the picture on the right, you can see just that is enough. It doesn't have to be the full coverall. It's important to note that. And these are some of the people that we work together then. There, I'm in the middle with Professor David Brett Major, who was an infectious disease physician from Nebraska, who was working with WHO at the time. And he was one major guy who really helped us to counter this terrible disease. At that time, he walked. And he was one of the first people to train us at the time. And the other person is a professor from Italy who came to take over from him when he was leaving. And we could see the Nigerian contingent, a lot of the staff at Yaba then, and some of the guys from Argentina. But the challenge and the sad thing is that many of these people, that's the local workers, have left the country. Some of them have retired. and we are not as equipped as we are to deal with these problems compared to 11 years ago when it first came in. So quickly now, we're going to be talking about the transmission and the pathogenesis, but I'll focus on the transmission. It can be animal to human transmission, which is contact with infected wildlife, fruit bats, monkeys, apes. But that's not our concern in IPC as such. But it's important to note maybe eating infected animals, handling infected animals, or killing them. And we believe that this current case in Congo may have resulted from that. We're not sure. But human-to-human transmission is where we come in IPC, because that's our job. That's what we want to prevent. And for the human-to-human transmission, it could be from direct contact with blood or body fluids of infected persons. It could be contact with contaminated objects, formats, needles, medical equipment. It could be contact with deceased patients. Now, the deceased Ebola patients has a lot of high viremia, because the viral replication in them is so high as at the time they die. So it's a lot of virus. They're highly contagious. And there's been a lot of cases linked to burials and all that. So it's very important to note that. And it can also be sexually transmitted, from human to human. But for healthcare workers, they face very peculiar risk factors. And some of those is because of inadequate PPE, it's never enough, or more importantly, inappropriate or improper donning and doffing. There have been a lot of cases that have been traced directly to acquiring the virus from when they were trying to remove the PPE. And I always tell people, PPE is not about wearing, it's always about removal. That's the more dangerous path, and where you have to be very, very careful. And that's where the place of training comes in. Sometimes PPE gives people a false sense of confidence, like, oh, I'm good, I'm protected, I'm secure. And then the appropriate protocols are not, they are not used. And I usually liken it to the case of someone who has gone to do a day shift and thinks that once they shoot him, it will not enter. So instead of him to avoid fights or not going to a gunfight, he's going to put his head everywhere. And then one day the audition fails and he dies. That could happen. And needle stick injury or sharp exposure, it's also a problem. Lack of proper isolation facilities. Many of our centers are not designed with isolation facilities in mind. And at any point where there's a case that we need to be isolated, there's usually a lot of panic. And because of poor isolation, that could be a problem. Inadequate training on infection prevention and control is also a big issue. There has been a lot of attempts to scale IPC knowledge and training in Nigeria with the work of CCAPs, working with NCDC, various grants everywhere. I've been a beneficiary of some of those programs myself. But there's still, in terms of, it's still a very low percentage of healthcare workers that are trained in this. And it could become a problem here because you're going to overwhelm the people who have been trained. I remember during the last outbreak, I knew people that threatened to resign. I knew people that walked away and said they're not going to touch this because they're not just going to do it. And it's just a bit of a challenge. And that's there's a call on us to train people. You can't do everything. I was part of the front line then. I'm not sure I will be allowed to do that now. I may have to do other things if there's an outbreak in Nigeria today. So there's a lot onus on us to train as many people as possible, especially the younger ones who have the strength and the endurance. When you do 3 hours in the isolation ward, you're sweating like a goat. It's a very, very thankless job, and you must be very physically robust to do that. So that's that about transmission. Again, it's very important for us in IPC. We know a lot of what we do is based on the chain of infection, and it's important to note that it's basically a contact virus. That's the most important way. Contact with blood and body fluids. It's not droplets, it's contact, which can be direct or indirect contact, but it's basically a contact virus. And we know what that means is that a lot of emphasis is going to be on hand hygiene. Okay. And we're going to do a bit of droplet precautions around that, and sometimes we might go airborne, but that's all because it can be acquired by secondary contact. Okay. So what are the clinical manifestations? Just run through this quickly. It's early symptoms, usually sudden onset of fever. There could be headache, muscle pain, myalgias, fatigue, and there could be weakness. And then you could have vomiting, diarrhea, very prominent. We had guys that were losing almost 3-4 liters in a day. I remember at that time when we had the last outbreak. There could be abdominal pain, very bad one. You could have rash, you could have chest pain. Hiccups is also something that could be there. The severe symptoms, which you get start getting worried when you have them, is bleeding. I've not seen a bleeding Ebola patient that survived. I don't have the experience. I've seen a lot anyway. But once they start to bleed, it's a slippery slope. Okay, it's a slippery slope. Now with Lassa fever, we've seen some patients that bleed and they come back. But once they start bleeding with Ebola, they just start losing blood everywhere. It's could be very, very bad. And then at that point, it becomes confused. They have seizures. They could get into shock, multi-organ failure, and go into respiratory distress. And then sometimes that's it. They go into a better place. What are the differential diagnoses? And that creates a big problem because fever is one of the most common presenting complaints in our environment. Malaria, it could just be simple malaria. Typhoid fever, of course. Lassa is also something we're having a current ongoing Lassa outbreak. We have been having, in fact, the challenge with Lassa now is we're having Lassa in places we didn't have Lassa before, because I think Bauchi now is leading the case count. Lassa used to be the purview of Edo before, and then from there it's transferred to Owo, in Ondo State, or let's say Ondo as a whole. But now we're having a lot of cases in Bauchi, we're having in Taraba, and we're asking what's going on. Okay, so it's always funny when you have, or always not funny when you have 2-3 outbreaks ongoing at the same time. It's can be very, very stressful and very confusing on how to deal with that. Dengue is also a possibility. And of course, sometimes patients could have meningococcal disease. So this creates a big challenge because the problem we have is this. Once you label a patient as saying, this patient may have a VHF, in most cases, the normal care for that patient will crash. Okay? So everybody will run away. So if this patient, for example, needs an O&G consult, they will tell you, oh, I'm sorry, we can't come to see. This patient will not get laboratory tests done. The lab will tell you, oh, no, send to a special lab. So it becomes a challenge. So we usually have a lot of responsibility, personal responsibility, when we are making these assertions, especially if you don't have a lab close by. We are lucky in Lagos. We have the Center of Excellence Laboratory, CHASV. We're there. We get results within sometimes the same day, sometimes within a few hours. Okay, if you're out of town, it becomes a bit more difficult before you courier the sample and all that. So every time before a diagnosis is made, you must have the epidemiological linkage. Somebody can't just come with fever and say, oh, this guy has Ebola. No, you're going to kill everybody when you do that. But did you travel? The travel history is very crucial. Where are you coming from? Do you have contact with this person, that person? So we usually do a lot of trainings around this so that you don't mislabel patients. Because once you do that, you're actually going to hasten their demise. And it's always sad when you come back and discover that actually there was not, they didn't have a VHF, but now they've died. And then there's a problem. If you're not careful, people will not come to the hospital again. So it's very important. What have we been doing in Nigeria since these cases were announced? Okay. The NCDC, like I've said, they have released a public health advisory September 6th. They have done a dynamic risk assessment, and we believe that our risk is low for now, but we are not slipping. It's a dynamic thing. We are reviewing every day. The folks in NCDC are doing that. When I say we, as if I'm part of them, where we are part of them by proxy, But there's a lot of activation that's done. A lot of EOCs, that the emergency operations centers, have been activated. I know in Lagos we have the EOC meetings that we screening the points of entry for at-risk people, and isolation facilities are already on alert. Abuja is well developed. Lagos too. We have done training for ambulance workers because they play a crucial role in this response. There's trainings that are going on at our infectious disease hospital so that we are ready. The laboratories are on standby. Okay, kits have been prepared, because the laboratory play a very critical role in this. It's not a clinical diagnosis. You know the lab. Okay, so the laboratories are on standby, and public health teams are also ready for contact trace. Okay, because once you have a case, you must look at the secondary contacts. So a lot of work has been done. A lot of work is still ongoing. And this is part of the work. Okay, we're also playing our own path in making sure that we are sensitizing people, we are training people. And it's very interesting to note that many times when these diseases come into the country, they don't come into the public health facilities. In the case of Ebola, like I've said, presented at a private hospital in Obalende. The first case of COVID in Nigeria was actually at the company clinic, Lafarge Clinic in Ogun State. So it's very, very important to note all these things and not think that it is only the teaching hospital that has to be covered, because sometimes that's the mistake that we make when we are doing our trainings and our preparedness. We focus on the public facilities, forgetting that the average Nigerian, including many people on this call, will never go to a public hospital for basic symptoms. Public hospital is usually the last port of call, when we are doing that. I've talked about the 2 suspected cases we have in Nigeria so far. Thankfully, both of them returned negative. So let's quickly get into the meat of this discussion over the next 10, 15 minutes. What we'll talk about the infection prevention and control that we need in Ebola, okay? Like I've said, it's a contact virus. So we need to take contact precautions. For any precaution we're doing, we know our standard precautions has to be involved. And the most important thing we know is our hand washing. Hand hygiene, very critical, okay? You have to wash your hands with soap and water. If that's what you have, alcohol-based hand soap, very good also, okay? In fact, better because of compliance issues, except your hands are visibly soiled. It's very crucial. And these are times to remind ourselves of hand washing. It's very important. There's always an index case, and you don't know who that index case will be. And that's why we call it standard precautions, because if you adhere by those standard precautions, it's not a problem. I remember during the last Ebola outbreak when some of the diagnosis was made retrospectively. Sometimes we have to go back to the emergency and say, oh, sorry, this patient passed through the emergency 5 days ago. It was a contact of this patient that eventually had Ebola. And then you see people shaking. You see people screaming, crying, wailing that, hey, I was part of those that managed the patient. What will happen now? Doctor, what's going on? And it's because they never took precautions. Okay, so it's very important for us to understand the role of standard precautions and to emphasize them. Patient isolation is very crucial. We must all have our isolation spaces ready to receive. We must have our holding areas ready. Okay, at least there should be one isolation center per state, and every hospital must have a holding area and a dedicated logistics plan for moving the patient to the designated isolation center in the state. For something like Ebola, we don't like to have multiple treatment centers, because if you do that, you're going to have multiple areas of transmission. So you want to concentrate all your risk in one place. So it's very important to note that. Environmental cleaning and disinfection, big deal. Big deal. Because of the issue of formaldehyde indirect contacts, it's very, very important to note that. And why it's more important is because our cleaners need to be trained. Many times when we are doing our training, we focus on the hierarchical staff, the doctors, the nurses. Everybody forgets the cleaners. And then sometimes these cleaners become the weak link in our chain of infection prevention and control. And eventually they are the ones that now come in and cause problems for everybody. So it's very, very important to include them in whatever we are doing. Make sure they have the necessary materials. They have enough bleach. We use bleach like pure water in Ebola. Now we know some of these things may not be necessary, but it's very, very important for us to get all those things ready. PPE. Big issue. Unfortunately, a lot of times that's the only issue some people talk about in IPC. We cannot manage patients. There's no PPE. But even these people, do you know how to use it? Do you know how to remove it? Do you know how to wear it? A lot of people still don't know how to wear masks. A lot of people don't know how to wear gowns. A lot of people don't know how to. And I tell people, I warn them, when it comes to Ebola, Ebola is unforgiving. It's not like COVID. Case fatality rate is always 50, 60%. So that means that for every 3 people that have Ebola, it's likely that one of them will die. So you have to be very careful. Okay? And the way we were trained then in the isolation facility, there's no hierarchy. A cleaner can look at you as a professor and say, sorry, sir, please, you are not following protocols. Please, you have to stop. Or you have to go out. Or you are looking too weak. Or, sir, you have raised your hands 2 times. You have tried to wipe your face. Please, leave now. And you have to go. Because any weak link in the chain, regardless of CADA, regardless of job description, can become a problem for every other person. Okay, so you must know the proper PPE to use. You must wear them properly, and most importantly, you must be able to remove them properly. Do a proper risk assessment. What do I want to do for this patient? We were trained to see Ebola patients without wearing anything. Sometimes, depending, if I'm clocking a suspect, why do I need to? I can maintain my distance, check where the wind is blowing from and all that. I'm not touching the patient. I'm good. I can go this way and interview a patient. And then if I need to move closer or I need to perform procedures, I know what I'm going to wear. So that risk assessment is very important because PPE is not an infinite resource. And when you use them poorly, we've seen a lot of outbreaks when the outbreak starts, we have all the PPE in the world, okay? And then 2-3 weeks, government has to move on to other things, okay? And then all of a sudden, we don't have PPE again. And then there's a challenge. And the patient care suffers because people are like, I'm not going to enter that place without PPE. So it's very important for us. I mean, we all know what happened during COVID. I mean, during COVID, I remember a time when I had to use one N95 for about 6 weeks because at that point, we're really rationing use of PPE. So rational use of PPE has to be practiced from the outset. Safe injection practice is very crucial. This is a contact virus. You cannot afford to prick yourself with a needle with HIV, with Ebola. Okay? So it's very important to note that. And let's not forget, just came into my mind, now we know Ebola has a treatment, unlike in 2014 when it came into Nigeria. Now we know it has vaccines. Again, unlike these are new developments. But unfortunately, these drugs are not widely available. They are not drugs you can walk across to a pharmacy to buy. They have to be procured through special orders from WHO and all that. So it's been a bit of a problem. But there's a treatment and there are vaccines, at least 2 vaccines, and there's a bit of vaccination going on. Some have asked that, why not let us vaccinate healthcare workers, because they are going to see the patients, but we don't have enough. There are not enough funds for that. So even in Congo, what they are doing is to vaccinate the secondary contacts of the primary cases in a bit to stop patients from even coming to the health facilities. Those are the primary recipients of the vaccine. If you have more than enough, then you can probably stretch to the healthcare workers. So then waste management, big problem in Ebola, because waste is an issue. Your waste cannot, all the waste going into the isolation ward is termed as highly infectious waste, okay? If you're using your color coding system, it goes into the red bucket. You don't have general waste anymore. A paper goes there, it's highly infectious because you don't know what has happened to that. You don't know what's going on with it. So trying to deal with that waste can become a big issue, okay? It can pile up and all that. I remember back then in 2014, we had to get an incinerator for that. And then we're also able to use the incinerator to cremate some of the bodies for those because burial management is also very important, especially in a country where we have also some burial practices. And we know that the burial ground is a very good transmission point for Ebola, So we had burial teams that were highly trained. And we had a burial ground there where we buried some of those that wanted to be buried, but they were not public knowledge for even the family to know about it before some of them come back to say they want to hear your Popada, like some people with the Yoruba land to say they want to rebury the dead because they want to give the dead a befitting burial, and that becomes a problem. So, but some people also elected to cremate, and we had an incinerator to do that, and give them the respect that they deserve. So standard precautions should be applied correctly, regardless of diagnosis, please. You don't want to be that the person that sees the first case and you didn't take precautions. You don't want to be that healthcare worker that when they announce to you that, the patient you saw 2 weeks ago actually has been confirmed to have this particular disease, and then you start to collapse because you knew that you didn't take precautions. So let's be careful. Regardless of the diagnosis, that's the whole idea of standard precautions. What are the things that we need to do? Our triage, we must have our SIN protocol, we call it. That's the screening, isolation, and notification. Now, at this point we are in the outbreak, this is just going on at the point of entry. There's a bit of work that is starting there. Remember that these things are very capital and human intensive. But that's where we should be. But at our health facilities, I expect that all of us should have our designed protocols ready. We should have our audit areas ready. We may never have an outbreak. It may never get here. I remember the outbreak they had they had 1 or 2 Ebola cases in the US in 2014. And one particular center where they took the patient in Atlanta because they had to move one of the missionaries from Liberia then to the US because they believed they could give him more care. Eventually, he survived. They had been waiting for Ebola patients for more than 20 years, since the 1980s. Okay, so there's nothing wrong in getting ready. We don't have to wait and be jumping around every time that there's a problem. So we must have an SIM protocols. What's the notification process in your facility? They have the name of your state, the number of your state EPID. What's the process within the facility? We don't allow everybody to make that classification. Otherwise, we become a false alarmist. Okay. So, but you must have people who are designated to be able to make the call that there's a problem. And of course, everybody must be protected. Every single person. You must limit the number of staff interacting with patients. You have dedicated staff. And high index of suspicion is needed. Again, there's a lot of responsibility that you have to take when you are making this diagnosis, because it's very likely that their medical care will drop until a final laboratory confirmation comes back. You can't say a patient is likely to have Ebola, and then 30 minutes later, say, oh, no, it's not likely. Nobody will listen to you. Okay? So because they will tell you where's the result. So before you label a patient, make sure you have all your case definitions right before you label a patient as a suspected case. Of course, our isolation room, we know there's the green zone, which is for the workers and for supplies. We know there's a yellow transition zone, and they know there's a red zone. And we must have, so unfortunately, a lot of gains we had from COVID have been lost already. I don't know how many of our facilities still have our isolation centers that have not been converted to other uses or even totally non-existent. So it's very, very important to have all that ready. Biohazard bags and all that should be ready. Dedicated medical equipment, single occupancy room as much as possible. Not face me and face you, not just one room, not a dormitory. You understand? So that we don't cause a lot of transmission. PPEs, like I said, a lot of things have changed. We don't need the full Tyvek. That's coverall. We can do with this, just the surgical gown. And then we have our face mask, our shield, and that's about it. We don't even need to wear boots. It's not very necessary. Again, foot baths, we don't need it anymore. If we have boots, it's fine. If we don't have it, we can move with that. Okay, N95 may be needed sometimes if you are doing an aerosol generating procedure. This is not an aerosol. This is not an airborne pathogen. It is majorly contact. Okay, donning and doffing procedures, very important. I won't be able to go through all that, but it's very important for us. There are a lot of arguments as to whether you need one or two gloves. I think a lot of times it depends on the scenario. Sometimes some people use one. Sometimes some people use the inner and the outer glove. It all depends on. And I wanted us to take through all that. For healthcare workers, again, our standard precautions, same injection practices, waste management, environmental cleaning, specimen handling, very crucial. Not everybody has a lab in their backyard. So how do we transport the samples so that we don't create points of spread from the blood? So we know this blood is highly contagious. It's very, very important. We usually have this triple bagging that we do. We take the sample in an EDTA bottle, put in a urine bottle, a bottle for urinalysis, and then we put that in another bag or envelope, just to create multiple levels of protection. Your equipment should be dedicated, and I've talked about the barrier tips is very, very important. Healthcare workers are at extremely high risk. We have seen all the outbreaks. There's a disproportionate toll it takes on healthcare workers because we are the ones that face these patients directly. It is very, very important for us to strictly adhere with infection prevention and control protocols. So what the last 40 minutes try to take us through the current Ebola outbreak in Congo DRC, which was declared in September 4. I've also taken us through previous outbreaks in Nigeria in 2014, which I was a major critical part of the outbreak. I was one of the first Nigerian doctors to be involved in the care of patients. I've also talked about this current outbreak in the Nigerian perspective in terms of the alerts that we've had. I've spoken about the transmission of this virus. I've talked about the importance of standard precautions and contact precautions majorly. I've talked about various parts of the standard precautions like hand hygiene, very crucial. PPE, very important. Cleaning, disinfection of the environment, waste management. I've talked about isolation and triage, the importance of us having all this in place, the importance of training, the importance of readiness. We hope this doesn't come, but if it comes, we want to be ready. Thank you very much for your listening.
Thank you.
These are my references.
All right. Thank you so much. Thank you so much, Dr. Adefolari. Please, can we appreciate our speaker with our best emojis in the chat? I want to believe that we have our questions ready. Thank you so much, sir, for sharing your wealth of knowledge. Very insightful perspectives to this Ebola virus disease. We really, really appreciate. Please, let's put together our questions. Thank you for a wonderful presentation, sir. Thank you so much. It's obvious that Ebola virus continues to remind us of how fragile our health systems can be in the face of outbreaks. My first question to you, sir, is Given that the early symptoms of Ebola may mix and overlaps with malaria and other febrile illnesses common in our region, and it kind of complicates outbreak responses. Please, sir, what are the early clinical clues that should raise suspicion to avoid misdiagnosis?
Oh, thank you very much for that question. I can't say that there are what we call pathognomonic signs, where, for example, if you have a patient with neck stiffness, you know that there's most likely meningitis somewhere. Okay. We don't have that. If you have a patient with spasms, rictus, and all that, sardonicus, you know that there's probably tetanus. We don't have that for Ebola because especially when it starts, it's very non-specific. Okay, with a lot of it's fever, there's muscle aches, there's nausea and vomiting, there's diarrhea, there's a rash. A lot of people could have that. And then there's bleeding. Okay. So for example, the last case that came into Nigeria, the case in Abuja, patient had fever that was not responsive to antibiotics, it was bleeding. Yeah. So that was a high index of suspicion. So there's really no clinical sign that we can use. And that is why, unfortunately, it is until people start to die that people know there's a problem. That's the truth. Almost every outbreak is associated with healthcare worker deaths before people know that there's a challenge. So, but now that we are being sensitized, what we need to do is to have what we call our epidemiological linkage. If somebody has not traveled, regardless of whatever it is, we are not going to say that that's a case of Ebola. That's going to be wrong. Okay? But you must have your case definitions, your suspect case, your probable case, your confirmed case. Every suspect case must have an epidemiological link. Again, because the major challenge is that once you label a patient, I can assure you, nobody will touch that patient again until you unlabel the patient. So for now, you can't come in to say you have Ebola in your area. It's not going to work. Again, if you come into anywhere in Edo State or Ondo State with fever, you have a funny rash, you have conjunctivitis, it's Lassa fever, otherwise proven. Okay, it's not the same thing for us in Lagos. So the epidemiology is important in this, making this diagnosis. But in terms of clinical sign, there's no sign that you can really say it's a sign of Ebola. Thank you very much.
Thank you so much for that insightful perspective. Thank you so much. I'm looking through the comments to see if we have more questions for our speaker. Please, if you have a question, do well to raise your hand. I'm trying to check if we have questions. If you have comments, contributions, the floor is open now. Okay, all I'm saying is thank you for insightful, okay, very wonderful presentation. So please, sir, what are the lessons from the current outbreak in DRC for other countries like Nigeria? What are the lessons that we should pay close attention to right now so that we do not, just avoid a repeat? Okay, so their hands up, So let me give them the opportunity to ask questions. Okay, please go ahead. First of all, Dr. Ifeanyi, I'm going to unmute yourself. Go ahead with your question.
All right.
Please go ahead, sir.
All right. Good afternoon, everybody. I believe you can hear me.
Yes, we can hear you.
Okay. Thanks so much for this sensitization and awareness. Yeah, you talked about, in answering to the last question, where you made mention that there are no clear clinical indications to show that one has Ebola. I was thinking probably they will have to be all those bleeding through the nose, bleeding through the mouth. Isn't that associated with one of the signs or symptoms of Ebola? That's one question. And again, if we have a suspect, if there's a suspected case, what is in the next line of action? Where can we now make a report or refer the patients to? These are my questions. Thank you.
Thank you very much, Fiain. So, sorry, do you want me to take? I think I should quickly answer some of those questions.
Yes, sir. You can
Okay.
go ahead.
So, if I sorry, where are you calling from?
All right, yeah, Delta State.
Very good. So, one of those things I talked about was the SIM protocol. That's the screen, isolate, and notify. So every area must have that protocol in place. Because what the question you're asking is a very valid question, which was what happened in 2014. All of a sudden, and I never came. And Amaya was a pastor. I mean, I knew her very well. And she was like, I have this case, so I read something. It's looking like Ebola. What do we do? Confusion everywhere. Pandemonium. Okay? Because we didn't have these protocols in place. So you say, just keep him there. Keep him there how? And then this man woke up and said, I'm leaving. I came to Lagos for a meeting. I'm well enough. I'm going for my meeting. You cannot go. And then there was a problem. Okay? And eventually, I mean, it was very sad. People died, because we didn't have all these protocols in place. So it's very important to have your own local protocols. So if the patient comes to Delsu in Ogara, or patient comes to FMC Asaba, I don't know which center you are from there, sir. Delta is one place I've been to quite a few times, and I've lived there. What do we do? What's the local protocol? Is everybody aware? So you must have that protocol. Now, my protocol in Lagos is different from your own. In Lagos, we already have all these things. We have our networks. So that once there's a case, we know the alert systems to run through. When there is a case in Lagos today, 1 or 2 phone calls, I can raise an army of up to 30 people, because immediately we start contact tracing, immediately we're on the news, case management, everything, we have it very well organized here. Because once you see their call, you know that there's no sleep again, because there's a case. Okay? But everybody must have that proper structure from the facility level to the state level, from the state level to the national level. Okay? Because this is a national response. So anytime you have that, so you must have that. So the question to ask is, do you have that structure in place in your hospital? If you don't have we created it? And like I told you, it's not only for Ebola, is not the only notifiable disease. If you have rabies, you must notify. If you have meningitis, you must notify. Tuberculosis, ideally, you should notify, so that there can be proper public health response to all these things. I don't know if I've been able to answer your question. In terms of clinical features, I'm a clinician. I'm an infectious disease consultant. That's my primary specialty. And I can assure you that there are quite a lot of diseases that come with bleeding, fever. If a patient has low platelet count, it will bleed. Okay? A patient has a malignancy, it could have fever and bleeding. Okay, so you can't just say there are no clinical signs that you can use to diagnose. A lot of times the epidemiological linkage plus the clinical signs that you are using, but most importantly, the laboratory confirmation before you can say that the patient has Ebola. Thank you very much. Next question.
Okay, so please go ahead, Dr. Kemi, go ahead. Unmute yourself.
Okay. Good afternoon, everyone.
Good afternoon.
Dr. Power, thank you for that beautiful presentation. Please, I'm Kemi Tuta. My question is concerning the case management. Can you throw more light on it concerning the medications on treating that patient? Thank you.
So because this is an IPC meeting, I didn't want to dwell too much on that. But like I said, initially when we were managing patients, then we focused only on supportive care. So we gave a lot of fluids because a lot of them had terrible diarrhea. So we gave a lot of fluids to counter that. And then we treated the electrolytes, gave them oxygen for those who needed it. But now we have specific treatments. We have monoclonal antibodies. Imanev, Zebanev, monoclonal antibodies that are used. We have vaccines that are used. So in the treatment now, the treatment protocols now include a lot of these things, plus supportive therapy. Because sometimes they come with this terrible dehydration. Okay, because of the fluid losses that they are having and all that, So, and for example, for the cases that went to the US, they went as far as putting the patients in ICU and all. Now, with a lot of experience we've had with Lassa fever, we know we can actually manage this patient in the ICU, we can do dialysis and all that. So many times there's a lot of focus on supportive therapy, but now we have definitive therapies that can work for them. But I can assure you, we have cases in Nigeria today, there's no guarantee that we're going to gap the drugs because it doesn't pay the pharmaceuticals to produce them. So a lot of focus is still going to be on supportive therapy with your fluid replacement, oxygen therapy if you need it, and all that. But we have drugs that can work for it now. Thank you very much. Dr. Toby.
Thank you so much for that beautiful response, sir. Okay, so please go ahead, Dr. Godwin.
Okay. Good afternoon.
Good
Good
afternoon.
afternoon, sir.
Good afternoon, sir. Thank you so much for the insightful presentation on IPC. I'm calling from River State University Teaching Hospital. So my question is, you talked about it's very obvious that healthcare workers are at high risk of contacting this deadly virus. You also made mention of the case fatality ratio around 50 to 60%. So my question is on the vaccines. What is the federal government doing to ensure that these vaccines are also made available? You mentioned during the course of your presentation that the vaccines are only given to those that have secondary contact with a suspected case. So my question is healthcare workers are at risk? Since healthcare workers are at high risk as well, so should there not be more advocacy to make the vaccine available for healthcare workers? Thank you.
Thank you very much, sir, for your very beautiful question. So one of the challenges that you face as a medical practitioner where you are in senior management is the distribution of resources and resource allocation, because death is death. And you have Ebola, it's killing people, fatality rate is 60%. Rabies fatality rate is 100%. Many people that have 2 strokes, they will not survive. Okay? Malaria is still killing people, though not so much as before. And I'm just coming from the hospital. I lost a patient to viral encephalitis yesterday. I lost another, no, that was 2 days ago. Yesterday, I lost a patient to metastatic cancer. And then today now, I have TB. I have a case of TB meningitis. I have another one with disseminated tuberculosis. I have one with, more cervical site infection following the myomectomy. There are all sorts of problems. So you have to look at what is important. What can I handle? Now, for now, if you're asking the federal government to go and start looking for vaccines for something that may not come to Nigeria, I don't think that's a good allocation of funds. Every day in Kaltungo, in the Gombe State, during the rainy season, sometimes you have up to 100 cases of snake bite. And sometimes almost 10% of them die. Okay, so the question is, do we need vaccines now? I don't think so. There's a challenge with production of the vaccines. There's a challenge with having enough. So even in Congo, where they're having the current outbreak, the emphasis is on the contacts. Okay, for the healthcare workers, their own emphasis is on PPE. But because you don't wear PPE in the community, it is believed that they are at higher risk. Now, if there's a serious problem, they're going to hopefully increase the volume of production of the vaccines, and then they are going to make it available to a wider range of people. But for now, I think the focus should be, for us in Nigeria, on protecting our borders. Remember, in your chain of transmission, okay, the earlier you catch the disease in the chain, the better. And when you want to prevent at the level of the reservoir, is to cut it off and make sure you do your isolation properly. If the disease doesn't get in here, then the whole idea of vaccines becomes redundant. If, God forbid, we have an outbreak in Nigeria, then this advocacy becomes very important. But for now, what we are doing now is what we need to do. Strengthen our borders, make sure we are ready. If the first case comes, we can have another discussion on the vaccines. Thank you very much. Dr. Toby, please.
Please go ahead, Dr. Toby.
Dr. Toby.
Okay, thank you very much. Good afternoon, everybody. Thank you very much, Dr. Polari. Very interesting presentation. So my question just is on the PP requirements you spoke about. You said healthcare workers can actually go with just wearing a gown. and a single glove and may not even need Crocs. I don't know what's the rationale for that. I see Ebola virus as a highly transmissible virus. And I would think that at least basically they should wear a coverall, and when they're going in, depending on what procedure they're going to do more than just a nose mask. If it's they're going to have, there will be aerosolization somewhere down the line of procedure. I think that they may need no N95. But then please just tell me what's your rationale for what you said about
Thank you
PPE.
very much, Dr. Tobin. Now, Dr. Tobin is a very senior colleague from the Lassa fever headquarters in Nigeria. Though I think they are losing that crown to other states now. But you have a lot of experience with this viral hemorrhagic fevers. So, yeah. Now, you see, it's very funny that when you look at the PPE requirements, it's always different for different jurisdictions. And when you look at what the CDC would say, it's different from what the WHO would say, it's different from what MSF would say. But we always remember that MSF and WHO are basically geared towards the resource limited, or some people will say resource poor areas. Now, in terms of the science, based on what we know, this is a contact virus. So meaning that technically, you can't inhale Ebola and contact it that way. Technically, based on what we know. Okay, and if I'm wrong, please, I stand to be corrected. It's something that is basically through contact with some body fluids, contact with, because there are micro abrasions in the skin where these things can get in. Now, the whole idea of protecting the face, is because of what we call secondary contact, in which your hands go on to touch things and then use them to rub your eyes or to rub your nose or whatever, which we do a lot. Because I remember then one of the rules in the isolation center is your hands don't go up. Once you wear your PPE, your hands stay like this as if you're in the theater. Because once your hand goes up, it can go anywhere to your face and it's going to enter from there. So N95 has a cost problem. And because it's not a primarily airborne issue, if, for example, I'm going into the room to just clack the patients or just talk to them, hello, how are you? How are you doing? How's everything? How are you feeling now? I'm going to take vital signs. Do I need to wear N95? No. If I'm going to intubate, it's another story entirely. If I'm going to suction, that's different. If I'm going to do CPR, that's different. So it's very important to always do a risk assessment as to what we need to do. And it determines the kind of PPE we need to wear. Now, it's very important to realize that PPE is not an inexhaustible resource. Even during COVID, I remember, initially there was a lot of gra-gra. We were using N95, we can use like 10 in a day. After some time, when you put in N95 into your request, flew up that time. And again, resources are not infinite. So in terms of the science, I believe that we know, you are in a VHF that is very similar to Ebola in terms of transmission, just that it has lesser mortality and maybe lesser morbidity too. And I'm not sure you need to use, do you use the N95s all the time in Irua, Dr. Tobin?
No. So I only cited that because of if a healthcare worker is undergoing a procedure that will generate aerosols.
Yeah.
But my
Yes,
question was the gowns. Are we not? I know it's contact.
Yeah.
But yeah. So you're saying
do you think there's any difference between the Tyvek coveralls and your surgical gowns?
Well, the Tyvek covers better.
Yeah.
It covers better. Yeah,
I
but
agree with you.
Yeah.
I agree with you. So it depends on what you want to do. So, for example, if I'm going to carry a conscious patient that I cannot guard, I cannot account for how a lot of things during the procedures or during what I'm doing, I may want to wear a Tyvek because, like you rightly said, it's a full covering. But again, if I'm just going to examine a patient, do I really need a Tyvek? If I'm going to clack, if I'm going to set a line, do I need a Tyvek? No. I can do that very well with a surgical gown, do my procedure and come out. So that risk assessment, what we call POCRA, is very, very crucial. to know what we want to do and what we need to get. There are sometimes when people believe that prepare for every eventuality. But what we have seen with that is that you end up having more than you need, and then it ends up becoming a problem. Okay? Because all of a sudden now you're uncomfortable. When you wear a proper Tyvek suit, which I've done quite a few times, I can assure you in our environment here in the heat, without AC, after 30 minutes, you will understand that the concept of hell is real. Because you start to sweat, you start to get dehydrated. Well, if you're not careful, you start to feel woozy. And then your goggles will fog. I remember that time we used to urinate inside our goggles because the belief was that the alkaline nature of the urine will help to prevent it from fogging. We didn't do any study to confirm or deny that, but that was what we did, okay? Because desperate times require desperate measures. So PPE is very controversial, depending on which jurisdiction you're looking at. If you have all the resources, go for it. Full facial protection, everything that you need to get, go for it. But for our environment, we have seen that some of these things we can adequately protect ourselves without having to go all the way. The N95 definitely will give you better protection than surgical face mask. But the question is, do you need it? Okay, especially in a place where you have limited resources. Thank you very much. Dr. Aliyu and Dr. Joan, I don't know. Dr. Aliyu, please. No, I know Dr. Joan probably would comment on this. I mean, Dr. Aliyu. Dr. Aliyu, your hands are up.
Please go ahead, Dr. Aliyu. I saw the question that he put in the chat. Maybe I should read it. He said, I need a recap. He said, please, I need a recap of diagnostic criteria for VHF, particularly Ebola.
Diagnosis in the lab is in the lab, nothing else. You have suspicious clinical symptoms, suspicious epidemiology. Very important. In fact, the most important. Because if you are not careful now, I don't want the institution after this training, you get back to work and say, he has fever. He's vomiting. I can see some small blood on his hand. Hey, everybody, there's Ebola in Rivers State. Oh, there's Ebola in Kebbi. Please, it doesn't work like that. Travel history. Did you go to Congo? No, nothing. Move on. After some time, if there's an expanding outbreak, we expand the case definition. It's not Congo will now become, did you go to Rwanda? Did you go to Angola? Were you in Ghana? God forbid all these things happen. But we expand that. Without that epidemiology, no. But the gold standard of diagnosis is the lab. Now, that is why, like I said, you want to define your connections to your lab now. To say that, like if I asked, if we have a case today, where are we sending the samples to? How will the sample get there? When are we going to get the results? All those are things that we need to make sure of before that happens. So the diagnosis is laboratory, and you must have your strong connections with the lab to make sure that you can make your diagnosis on time and know what you are doing. So if I need to wear PPE, I wear. If I don't need to wear, I move on. If I need to start my contact tracing, I know. But everything is hinged on the diagnosis. Thank you very much. Dr. Joan, please.
Yes, go ahead.
Thank you, Dr. Powie, for that beautiful, brilliant, and very scintillating presentation. My network is fluctuating, so I'll just try to be fast. I just wanted to make a few points about what you said. I'm very happy that I brought up the issue of POCRA, point of care risk assessment. That determines how much and what PPEs you need. And if you look at the hierarchy in the strength of prevention, we know that PPEs is actually the least on the ladder because PPE1 only acts as a barrier, and when not utilized properly, it doesn't actually remove the hazard. So when it's not utilized properly, it will becomes a hazard in itself. So that's one thing we should keep in mind about PPs, as he has mentioned. Then I also want to address the fact of, I love what you said about standard precautions. That is why it's always said, what you do every day, every time, when you come in contact, when there has to be care delivery. Because if your standard precautions is not top notch and waiting till after a patient's diagnosis come out, unfortunately, we keep seeing the cases of doctors, healthcare workers dying from Lassa fever. During the 2014 Ebola outbreak, there was a patient that was managed in a hospital in South Africa. The patient was managed and discharged. They did not know they managed the patient with Ebola. Till a year later, they just decided to analyze all patients' blood samples that came in that period, and they discovered they actually managed the patient. Why didn't healthcare workers come down? Because at that time, they had institutionalized infection prevention and control practices, and that is what we need to do as a nation. Unfortunately, just as you mentioned, post-COVID in quotes, because they're actually seeing symptoms that still resemble COVID, we tend to have dropped down the emphasis on IPC. Then still, with respect to high index of suspicion, we should also keep in mind the role of epidemiology and disease transmission, because this disease transmission helps us to also determine what the mode of disease transmission helps us determine the relevant PPs we need to do and at what time. Let me even give a story. There was a healthcare worker who needed to take because you need to screen for other common diseases when you see patients that are suspected to have Lassa fever. I'm talking of Lassa here now. The person put on a Tyvek suit to do a needle stick bleed for rapid diagnostic test for malaria. How do you fathom that? And of course, if it so can you see, we need to do a needle stick to do an RDT for malaria diagnosis, and then put on a Tyvek suit. And sometimes with the Tyvek suit on, if you're not within 30 minutes, you feel as if you are going to faint. So with these things are one expensive. So when the real scenario comes, I need the Tyvek suit, it now becomes out of stock, and then the health worker that needs at that time doesn't have it, and then other issues can come up. But we should always keep in mind the basic issues, standard precautions, understanding modes of transmission. And just as you mentioned about the use of the overall to protect, I think during COVID, during droplet transmission as regards COVID, we know that because of the science, well, we know that most droplets will land within 3 meters from the source where it is produced. And if you don't need to come in contact with the patient and you maintain your 3 distance, typical your ward or laboratory coat would suffice. The important thing going forward is, of course, hand hygiene, because it's now the hands that can transmit droplets to either your own eyes or to another patient, or your own mucous membranes or another patient's mucous membranes. So the science still remains the same. The important thing is that we should keep in mind the disease in question and the modes of transmission. And then, of course, point of care risk assessment. What do you intend to do? What PPs do you need to use so that the BP itself does not become a hazard to you? So once again, thank you so much, Dr. Powe. Thank you, and over.
Thank you so much, Dr. Joan, for that beautiful contributions. Very, very insightful. So I'll give Dr. Anthony the opportunity to ask a question now, make a comment. Go ahead, sir, please.
Hello, thank you very much for the presentation and even this latest contributor. Really, really enriching. At the point I put on a question, but I think it has been taken care of. My question now is, the emphasis has been on laboratory diagnosis. I wanted to know how sensitive and how specific this lab test is. Do we have false negative or false positive? I think that's just so that in most cases, sometimes most of the tests will come out negative. But how specific and how sensitive? Thank you very much, and over.
Okay.
Thank you very much, Matt. Those are the kind of questions that people don't ask during some of these presentations. So why will I answer this one now? Yeah, so basically, there's no test that is 100%. That's the truth. There are false positives, there are false negatives. And that's why, like Dr. Jones said, and I mean, like our training as healthcare workers and especially as clinicians, is that you almost always have a 3D view of a patient. You are not treating the lab, you are treating the patient. You are not treating the result. So if I send urine for a man and they come back and tell me that man is pregnant, I said no. If we're in America, I would say, okay, maybe he has transitioned. But in Nigeria, there's an error. So it's very important for us to realize that. Now, a lot of times the tests are negative because the patient is negative. It's a DNA-based test. So the sensitivities are pretty good. The sensitivity and specificities. I don't have I don't have the data now to say, oh, it's 90, it's this percent or that percent. But I know sometimes, and I've had these issues before when it looks so much, especially like Lassa fever, like this guy is having fever, it's not responding, he's bleeding, and they're telling us it's negative. Are you sure they even ran the test? Maybe it's a scam. I've had those kind of questions, to be honest. And but most of the time, we've had patients, they go back home, they're fine. There's nothing to worry about. So the tests are not 100%. That's what I can assure you. But I think they're closer to 80 to 90%. I don't have the data on the exact specificities. It's when you do a test, and even to do the test will be difficult because the test, what are you going to use as the gold standard to test that, So, but many times when they say it's negative, let's trust our laboratories and know that it is truly negative and we move on. You understand? There have been times when we have called the lab into question. Okay? Some of these are things that we would not say in large open gatherings. Yes, I can assure you there are results that have come out and we say there's a problem. And we've had to do a double check, run it in other labs, do genomic sequencing and all that. But when it comes to public health, you always err on the side of caution. You understand? So if it has any strand of looking positive like this, they rather say it's positive than to careless and say it's negative. Nobody wants to be the person that released problems into the society. Like the first case of COVID, that sample was run almost 3-4 times before Professor Bilabu called Chikwe, who was the DG then, to say, oh boy, there's problem. And that is the level of responsibility that everybody in this chain faces. I can assure you, if a case of suspected Ebola comes into Nigeria today, we're going to run that test several times before we come and say it is positive. But if it is negative, it's clear. Okay? So it's very important to realize that, but always look at it. And that's why when we're also sending inquiries to the lab, let's give them all the clinical information that they need so that they can also, because sometimes, for example, now if you come and say, this guy, he just came back from Congo 3 days ago, he's having fever, he's bleeding. That kind of test, they will not just run it once and say it is negative. Okay? They will run it like twice, 3 times, because everybody makes mistakes. I don't know if I'll be able to answer your question, ma.
Doctor, thank you very much. Very well.
Thank you, ma.
Thank you very much for the answers and the presentation. Very great. Thank you, sir.
Okay, thank you so much for that beautiful response, sir. I've just shared the feedback form, and please oblige everyone to use the feedback form. We'd love to know how we can improve on the program. Okay, so while I read one of the comments here in the chat, it says, considering what we're facing nowadays and the state of our nation, as a healthcare practitioner, our PPE should be a priority in all patient contacts. Again, point of care risk assessment should be carried out whenever we want to see a patient and the type of procedure we're to perform on the patient. Okay, great. So there's another comment here. Thank you very much, sir, for the answer. As I understand from the answer, laboratory is the main important diagnosis. Which test are we requesting for blood culture or just to take blood sample and write for Ebola? Is there ROTD like for hepatitis and other serologies? That's a question from the Talio.
Don't do blood culture on Ebola patients. So, yeah. So it depends, really. Again, what we know, and when we get more and more comfortable, like when Lassa fever came, we're very limited in what we could do, but now we could manage Lassa fever patients in the ICU, and they are fine. Dr. Tobin is on this call. They've done a lot of this kind of things. So you run all the tests that you need to run. To make a diagnosis, what you need to do is to run a PCR test, which can be done in any standard gene expert lab. BSL-2 is fine. Usually we love to use BSL-3, or if you do a good BSL-2, you can run it. Okay? And a lot of those were actually converted during COVID. So you can use it. It's the same system, but different kits. Oh, you understand? So what you need to diagnose is PCR. Okay? And once you send it to a lab where they do it, but this is not something you send to same lab, please, or to any of the common labs there. And that's why you have to be connected to your state epidemiologist who is connected to the national epidemiologists and the national grid. Okay, we have a system of labs all over Nigeria, and every state has assigned labs. So that and then we have a courier system. Okay, so that once you activate that system, that sample will get to where it's supposed to go to. The system is not flawless. The system is not without hiccups, but there is a system. So your job is to know the system and be aware, so that when you have a case. Now, in terms of your other tests, if you have a good lab that has very good biosafety protocols, you can biosecurity, you can actually run your labs there, your full blockant electrolytes, all those things, because there's a lot of work that you do with the other things. So, for example, during our time, we have very advanced labs in Lagos where they have good biosecurity, so that we can run all these labs without having a risk of spread there. Remember that it's majorly a contact virus, so it's not so much of a big deal. So run all the tests that you need to run for your patients, but very important to know where the PCR tests are run. Thank you very much.
Thank you so much. It's really
sorry. So I just quickly checked, and the sensitivities are actually close to 100%. You understand, 91 to 100, 96 to 100. So sensitivity
that's
and
interesting.
specificity. So if they say it's negative, it's positive, it's positive. Yeah, thank you.
Thank you very much.
All right. Thank you so much. It's really been a very insightful and interesting presentation today, and I'm sure everyone enjoyed it. We're going to be sharing the recorded section as well as the slides with everyone. So, Dr. Adefolari, we really appreciate the time that we have spent with us today, and that's why we also have our certificate of recognition up on the screen. We recognize your invaluable contribution on this very important and timely topic, EVD, updates, epidemic preparedness, and also IPC measures. It's really been a wonderful section today. Thank you to everyone who has been able to take out time from their very busy schedule to learn today. And this is Nigerian Society for Infection Control. For those who are joining us for the first time, we're committed to fostering excellence in IPC through collaboration, education, and advocacy. And we're committed over the years improving quality of healthcare delivery, safety of patients and healthcare workers in Nigeria through the correct application of effective and evidence-based infection prevention and control practices. It's really been a wonderful time here today. Thank you once again to our speaker. We do well to share the recorded section to everyone whose email is on our database. It's been a wonderful time here. Thank you for all the comments, the contributions from everyone, and we really appreciate your presence. And we look forward to having you once again last Thursday of every month. We have this regular monthly meetings, yes, because it's very important to us that as healthcare workers, we continue to learn and relearn. It's really been an insightful time today. Thank you, everyone. Thank you once again to our speaker. I can't stop saying thank you. We really appreciate the time that you have spent with us to share from your wealth of knowledge. All right. So at this point in time, we'll have to draw the curtains. It's almost 3:30. It's really been a wonderful time. We didn't even know when it got to 3:30. That's to tell you how beautiful this presentation was today. I don't know if there's any more comments from Dr. Showade. Please, are you on the call? I'm not sure. Okay, so if there is no comment from our chairman, I don't know if she's still on the call, but I noticed she was here minutes ago. All right, so at this point, I'll draw the curtains, and please though, I shared the feedback link. Please do well to take out time to fill the feedback form. Let's know how we can improve on the program. Thank you to everyone. We really appreciate that the time that we have spent today. Yes, very impactful lecture, very impactful. We're going to share the recorded section as well as the slides with everyone. And do have a great evening ahead. Thank you. Goodbye to everyone.
Thank you. Bye.
Bye.
Bye-bye. Thank you.
Thank you. Thank you. Bye.
All right. Thank you.
Thank you.
Thank you so much. Thank you. Bye-bye.
Thank you so much. Thank you very much, sir. Thank you, sir.